Next, we're going to talk about one of the vascular causes of retinal diseases, namely diabetic retinopathy and its related condition of diabetic maculopathy. As we know, about 1 in 20 of the population will develop diabetes at some point in their lives, and the incidence of diabetes increases with age. So early detection and treatment is essential to prevent visual loss. And there are lots of very good screening programs, particularly in the United Kingdom, which is coordinated at a national level and hopefully reduces the prevalence of serious sight-threatening eye disease. Despite that, there is a lot of visual impairment due to diabetes in society today. So diabetic retinopathy can start as non-sight-threatening, asymptomatic background retinopathy. And you can see here the hard exudates representing proteinaceous loss through the leaky capillaries, and a few little blot hemorrhages representing blood loss through leaky capillaries. Pre-proliferative diabetic retinopathy just represents a lot more of these signs, but it still has very few symptoms of visual impairment. But then comes the devastating and sight-threatening problem of proliferative diabetic retinopathy. These new blood vessels that you can see here around the optic nerve are very fragile, cling onto the vitreous humour in front of the retina, and can break off and bleed just with small movements of the retina. That causes vitreous hemorrhage, which heals with traction and eventually pulls the retina off the back of the eye. It's very difficult to restore vision when that happens. So proliferative diabetic retinopathy is caused by microvascular occlusion, whereby the resulting hypoxia causes ischemic factors to be released, stimulating new blood vessels both peripherally in the peripheral retina here, but also centrally. And you can see around the optic nerve and the nearby macula, there's lots of new blood vessels in this particular picture. Then vitreous hemorrhage and tractional retinal detachment occur. Eventually, new blood vessels can form in between the cornea and the iris, blocking off the outflow of fluid from the eye and causing rubeotic glaucoma, which is another way in which patients with diabetes can go irreversibly blind. By contrast, diabetic maculopathy is now the most common cause of visual loss in diabetes because we can often find and treat diabetic retinopathy before it becomes a problem. Diabetic maculopathy also is caused by leakage from microaneurysms, but is more characterized by edema, that's leakage of fluid around this avascular fovea, which is a 0.5 millimeter, completely devoid of blood vessels. It's characterized by exudates, and we saw that on one of the previous slides. That's leakage of protein through the leaky capillaries, sometimes called hard exudates, and causes loss of central vision. Treatment for diabetic retinopathy is by laser, and also treatment for maculopathy is through very gentle laser by reducing the retinal ischemia. Non-laser treatments are available, and of course we can all take part in counselling our patients to get tight glycemic control, tight control of hypertension with drugs, cessation of smoking, loss weight and exercise, and treating anemia and renal disease. These can all help to prevent or slow the progression of proliferative diabetic retinopathy. ACE inhibitors are important both for renal and retinal disease in the setting of diabetes. We can also perform surgical removal of the vitreous called vitrectomy, or inject steroids and these days anti-vascular derived endothelial growth factors into the eye. Another of the vascular causes of retinal diseases is hypertensive retinopathy, which causes constriction of the arterioles. And you can see this arteriole has been almost completely obliterated, possibly by an embolism. You can get generalized constriction of the blood vessels as well. Sometimes you can get this arteriole actually pinching and diverting the course of the vein, so-called AV nipping. And here it is here as well. Outside of the blood vessels themselves, you can get flame hemorrhages, which look a bit like diabetic retinopathy, and so you shouldn't leap to one diagnosis or the other without testing both the blood glucose and the blood pressure if you see retinal hemorrhages. Similarly, if you see hard exudates at the macula and cotton wool spots representing ischemia of the retinal ganglion cells, that can also look like diabetic retinopathy. So, test the blood sugar and the blood pressure before you arrive at a diagnosis. Finally, disc edema is a rare sign of acute systemic hypertension, and one should always test the blood pressure in the setting of papilledema. A central retinal vein occlusion is as described. It's an occlusion of the main vein draining the entire retina. It's usually caused by atherosclerosis of the adjacent arteriole, but is contributed to by hyperviscosity states, vasculitic states, and glaucoma. Sometimes, if it doesn't resolve of its own accord, laser treatment can help to prevent ischemia, which, if left untreated, can cause new blood vessel formation and rubeotic glaucoma, again very similar to diabetic retinopathy. Branch retinal vein occlusion is a similar sort of etiology to central retinal vein occlusion and is associated with the same risk factors. A central retinal artery occlusion is characterized by almost complete and sudden visual loss. If you get there within the first 4 to 6 hours, you might see a cherry red spot representing the only part of the retina that cannot develop edema because of the lack of ganglion cells overlying the rods and cones. And then the edema of the rest of the retina is what gives that white surround to the macular redness. It's usually caused by emboli coming up through the internal carotid artery into the ophthalmic artery. Treatment is usually unsatisfactory, and this patient has almost certainly lost their vision forever. But it's important to perform secondary prevention measures to prevent disabling stroke or a similar event in the other eye, and control of all cardiovascular risk factors in the usual manner is mandatory. A detached retina is characterized by a tear in the retina whereby fluid goes through that tear and lifts off the retina from behind. It needs to be replaced by surgery alone. Nothing else will cure a retinal detachment, and we generally have about 2 weeks to get this treated. The hallmark of retinal detachment is symptoms of floaters or flashing lights, also called photopsia. An inherited retinal disease is the group of diseases called Retinitis Pigmentosa. Although there are over 120 different types of RP, they're all quite rare. They typically present with visual impairment and tunnel vision and night blindness, and they could be inherited in all sorts of ways as well as being spontaneously inherited. There seems to be an overrepresentation of RP in medical school exams because these patients have stable disease and are very willing to come to examinations. So just take a time to have a look at this typical bone trabeculation pattern of pigmentation of the retina.